For a long time, when everyone knew the difference between a witch and a fairy, the one thing that they didn't know is the difference between a nerve and a tendon and how to treat these nerve injuries. In the early 1200s, people believed that these nerve injuries have to be repaired, that is, nerve suturing has to be done. But one man refused this claim, and that man is Claudius Gallon. Claudius Gallon was a very big name in the medical fraternity, and everything that Claudius Gallon said was considered as the gospel truth. One day, while doing dissection, Claudius Gallon noticed a very small white structure that was entering into the muscle, and he also noticed a large white structure that was leaving the muscle. So, this small white structure was actually the nerve, and this large white structure was actually the tendon. But Gallon confused these two structures and he believed that these two white structures are the same. Hence, he frightened all the surgeons by telling them that if they repair that white structure, that will lead to enormous amount of pain, that will also lead to convulsions and also lead to death. He had actually seen few cases of tetanus and had misinterpreted the cause and the effect. But this one statement of Gallon changed the whole course of nerve injuries. So the actual treatment of nerve injuries did not begin until 2 or 3 decades later just because of this one statement by Gallon. But all this changed after a paper by Albrecht von Haller. He made a paper on tendon injuries and he disapproved Gallon's error. That is, he told that the small white structure was actually a nerve and the big white structure is actually a tendon, and both of them require suturing and treatment. So that changed the advancement of peripheral nerve injuries, and in this session we'll be talking about peripheral nerve injuries and in special one nerve, that is a radial nerve injury. So first let's understand what are the topics we'll be dealing with. First we'll be talking about the general aspect of peripheral nerve injuries, and secondly we'll be talking about radial nerve injuries. So now let's understand the peripheral nerve anatomy. First we need to understand the nerve cell, and then we have to go into the whole peripheral nerve system. So first let's understand the nerve cell. This is a cell body and this is the axon, that is the neural tube of the nerve cell body. So this cell body contains something called as a nucleus. So there is a large central nucleus. So let me write that down. A large central nucleus is present. Also, there are presence of proteins within the cell body. There are multiple proteins within the cell body. These are the rough endoplasmic reticulum, also called as the Nissl bodies. Now, there are also presence of these hair-like structures in the peripheries of the cell body, and these are called as dendrites. Now this was about the cell body. Now let's understand about the axon. So this neural tube is called as axon, and this is supposed to pass the neural signals from the cell body into the end organ. So this passing of neural structures or the neural transmission is fastened by the presence of something called as a myelin sheath. So in the axon, there might be presence of a myelin sheath, and this myelin sheath helps in passing neural transmission faster because this axon is myelinized. These are your myelin sheaths, and then this axon is supplying the end body. So this is an end organ. And this part or the distal part of the axon is called as a terminal axon stump. Also, another structure we need to remember is between these myelin sheaths there is presence of a node of Ranvier. So this is the complete structure of a nerve cell body. You have presence of a nerve cell body with a central nucleus, a large central nucleus. Also, there are presence of proteins within the cell body that are the rough endoplasmic reticulum called as the Nissl bodies. Then you have a neural tube, that is the axon, which is connecting the end organ and supplying the neural transmission. Now, this neural transmission is fastened by the presence of myelin sheaths and the node of Ranvier. Also remember, there are dendritic structures on the axon body. So this is your nerve cell anatomy. Now this nerve cell, if it is enclosed within a connective tissue, that is called as an endoneurium. So this nerve cell enclosed within a presence of a collagen connective tissue forms the endoneurium. Now multiple endoneuriums enclosed within something called as the fascicle. So you have presence of a fibrous sheath that is enclosing multiple endoneuriums together, and that collection of endoneuriums within a fascicle is called as the perineurium. So we've talked about the endoneurium being the inside structure, and multiple endoneuriums within a fascicle is called as the perineurium. Now multiple perineuriums enclosed together within a fibrous sheath along with blood vessels form something called as the epineurium. So epineurium is the final structure. So you have presence of the endoneurium, multiple endoneuriums are enclosed within a fascicle, and these fascicles are perineuriums. Multiple fascicles enclosed with their blood vessels within a sheath. That sheath is called as the epineural sheath, and this whole structure is called as epineurium. So collection of fascicles is basically a peripheral nerve unit, and this is the whole structure. So this is the anatomy of how a peripheral nerve looks. We have three layers: the endoneurium, perineurium, and the epineurium. Now let's talk about what a peripheral nerve is and where is it derived from. We know that there are mainly two systems of nerves. One is the central nervous system, and second is the peripheral nervous system. So peripheral nervous system is derived from the spinal nerve. So these spinal nerves that are there are 31 pairs of spinal nerves in the body, and each of these spinal nerves represent a segment in the cord. So these spinal nerves represent a section in the cord, and these spinal nerves again subdivide. Either they branch out as single branches, or they form a collection of nerves that is called as the plexus. So these spinal nerves can give a direct branching, or they can form a collection, that is the plexus, and that forms your peripheral nerve system. So what is a peripheral nerve system's function? It is a mixed nerve. It gives out motor supply, it gives out sensory supply, and it also gives out autonomous supply. So you know that the peripheral nervous system is derived from the spinal nerve root, and this division can be a direct branching or through a collection that is called as plexus. What is the role of peripheral nerves? Three things. They are a mixed type of nerve which give a motor supply, a sensory supply, and an autonomous supply. Now let's understand what are the causes of peripheral nerve injury. So we'll be talking about various peripheral nerves that are getting injured. So let's understand the mode of this injury. So the most common cause in orthopedics can be a fracture and a dislocation. So because of any fracture, that fragment of the fracture can cause the nerve to get injured, or even a dislocation can cause a traction neuropraxia. So it can cause a tractional effect causing a nerve injury. Also a direct cut or a direct laceration or infections like leprosy, where you have nerve thickening and effect of nerve or more. So leprosy can also cause nerve injuries. Mechanical injury, that is any compression injury, tractional injury, shock, or friction injuries. So mechanical injuries also can cause nerve injuries, or even temperature variation, that is cooling and freezing, mainly causing frostbites. So in such cases, nerve injuries are common. Even thermal injuries, electrical injuries, and ischemia, when there is reduced blood supply in a compartment, that can cause nerve also to undergo damage. Most common presentation is a Volkmann's ischemia. Also, toxic agents can cause nerve injury, and a radiation cause. So these are all the causes where nerve injury can occur. We'll mainly be dealing with fracture and dislocations, also direct injuries, that is cut and lacerated wounds. So these are the most common modes. Other modes are also seen. So now let's understand the pathology of any nerve injury. So in nerve injury, the nerve first undergoes a degeneration process, and later on the nerve undergoes a regeneration process. So we have to understand how the nerve undergoes this degeneration process, and then how the nerve becomes intact again, that is a regeneration process. So let's understand the pathology. First is the degeneration. So whenever a nerve gets injured, so imagine this is your nerve. If there is any injury to that nerve, that will give two regions to the nerve. So there is an area distal to the injury and there is an area proximal to the injury. So we have to understand what are the changes that happen in the distal part and what are the changes that happen in the proximal part. So in the distal part, the first thing to happen is an axon degeneration. So first the axon gets degenerated. After that, the Schwann cell. So in this myelination, there are presence of Schwann cells. So they are the basic unit of a nerve cell. So these Schwann cells becomes demyelinated. That is, they lose their myelin sheath. And the third thing is a phagocytic activity. So there are presence of a lot of dead cells, and these Schwann cells and dead cells are eaten up by the macrophages, and that process is called as phagocytosis. So all that is happening in the distal end. So first thing, this axon is getting degenerated. Second, these myelin sheaths are now getting degenerated and the Schwann cells are becoming demyelinated. And third thing, these dead cells that are present are now getting eaten up by the macrophages, and that process is phagocytosis. So this distal part is getting involved first, and this retrograde degeneration that is happening in the distal part is called as the Wallerian degeneration. So this retrograde degeneration that happens first distal to the nerve injury is called as Wallerian degeneration, described by Dr. Wallerian. So the next is the proximal gene. So what happens in this region? So you know that the nucleus was in the center. Now because of this nerve injury, that nucleus is now going into the periphery. So the nucleus is getting converted to the periphery. Also, we know that there are presence of Nissl bodies. These Nissl bodies are the proteins, are the rough endoplasmic reticulum. Now, because the cell requires a lot of energy for the nerve to become regenerate, because of that, these proteins are being eaten up. So, these Nissl bodies are getting eaten up or getting dissolved, and that process is called as chromatolysis, where there is disintegration or dissolving of these Nissl bodies, and that process is called as chromatolysis. So, these are the changes occurring in degeneration. Remember that the first change occurs distal to the nerve injury, and the first change that happens is in axon degeneration. After that, the Schwann cells are becoming demyelinated. That is, the myelin sheath is getting lost. And then these cells that are around, the dead cells that are around, are getting eaten up by the macrophages, and that process is called as phagocytosis. Then the changes happen proximal to the nerve injury, where the nucleus, which was earlier in the center, is now going to the periphery. And also the Nissl bodies that are present within the cell body, because there is requirement of more protein, these Nissl bodies are getting dissolved, and that process is called as chromatolysis. So in this diagram you can see that this is a healthy nerve cell. You have presence of a central nucleus. Also you have presence of these Nissl bodies. These Nissl bodies are your proteins or your rough endoplasmic reticulum. Also there is presence of an axon, and there are presence of these myelins, and this is the axon terminal. Now imagine there is an injury. So there is a cut injury here, by a direct cut injury or a laceration to the axon body. Because of that, these myelin sheaths are now getting lost. So there is a demyelination process. Also the axon is getting degenerated. So the second thing that happens is an axon degeneration. Also these dead cells that are present are getting eaten up by macrophages, and that process is called as phagocytosis. Now what happens proximal to the injury? You can see that this central nucleus is now gone into the periphery. Also the Nissl bodies are now getting dissolved, and that process is called as chromatolysis. So this is the occurrence of degeneration, distal and proximal degeneration occurring in any nerve cell damage. And this retrograde degeneration occurring distally is called as the Wallerian degeneration. Very important to remember this. So now let's understand how does the nerve regenerate. We've talked about the nerve degenerating. Now let's understand how does the nerve regeneration process occur. So if this is the damaged nerve, where there is a peripheral nucleus and the axon is cut and everything distal to it is damaged. the first thing that happens is the proximal segment axonal stump starts to grow distally. So this axonal stump is now starting to grow distally. And if the endoneurium is present, this endoneural tube, if that is present, then with its Schwann cell being intact, then the axonal sprout will pass till the end organ. So if there is presence of that neural tube, so if around this region, the endoneural tube is intact all the way up to the end organ, then that will mean that this axonal stump can grow all the way up till the end organ. So that is only possible if the endoneural tube with its Schwann shell is still intact. So the Schwann cell and the endoneural tube have to be intact for that axonal sprout from the proximal end to regenerate all the way up till the distal end, till the end organ. Now the rate of recovery is very slow. So the axon grows at 1 mm per day. That is why we have to be patient in nerve injuries, because these nerve injuries will regenerate, but they regenerate at the rate of 1 mm per day. Whatever treatment you do, whatever intervention you do, the axonal regeneration still remains at 1 mm per day. So that is how slowly the nerve regeneration process will occur. And this nerve regeneration occurs in a pattern. That is, imagine you have a cut injury at the axilla region, and because of that there is weakness of the arm, forearm and the wrist muscles. So if there is nerve regeneration, the first muscles to regenerate are the muscles of the arm, and then it is the muscles of the forearm, and then there is the muscles of the wrist. So there is a proximal to distal recovery, and that process is called as the motor march. So the motor march is when the muscle recovery starts from the proximal and then goes to distal. So in an injury at the axilla, where the nerve is injured near the axilla region, the first to require is the proximal segment. The recovery of the first proximal segment is the muscles of the arm, and then muscles of the forearm, and then muscles of the wrist. So that process is called as the motor march. So all this happens when the endoneural tube is intact and there is also presence of Schwann cells. Now imagine if the endoneural tube is not intact. In such a case, what happens is these axonal sprouts, hundreds of these axonal sprouts will be floating around aimlessly around the injured area. So they'll be floating around the endoneurium, the perineurium, the epineurium, and these will collect in one area, and that will form something called as a neuroma. So when the endoneural tube is interrupted, in such cases there is formation of neuroma. There is no complete recovery. There is only formation of neuroma. And what is this neuroma? This neuroma is a collection of hundreds of axonal sprouts which are floating around aimlessly because they don't know where to go. So the regeneration process is not complete. They form something called as a neuroma. So this is a summary of a nerve recovery. First, what happens is you have an injury occurring at the nerve, and because of this injury, the distal segment is first to degenerate. That is, there is an axonal degeneration and these Schwann cells are getting demyelinated. Also, there is a phagocytic activity that is happening. That is the distal thing, and that is called as a Wallerian degeneration. Also, proximally, the central nucleus is now going peripherally, and the Nissl bodies are undergoing chromatolysis. So that is the whole process of nerve degeneration. Next is the process of regeneration. So if the endoneural tube is intact, then you will see that these axonal sprouts will start to go proximal to distal, and they will connect to the end organ. Also there will be myelination, and because of this there will be axonal recovery. But if the nerve is not intact, if the endoneural tube is not intact, in such cases we have a lot of axonal sprouts which are floating around, and they will form a neuroma. So this neuroma can be either a neuroma in continuity or an end neuroma. So there can be two types of neuroma, a neuroma in continuity or an end neuroma. So an end neuroma is where the proximal and distal part of the nerve have some discrepancy that will lead to formation of end neuroma. There is also formation of a side neuroma that occurs in partial tears of the nerve. So when there is a partial tear of the nerve, that will result in axonal sprouts only in the side region, causing a side neuroma. So this is the whole summary of a nerve recovery. If they completely recover, that will be when the whole axon is getting connected to the end organ. But if there is no end neural tube that is intact, endoneural tube is not intact, in such cases, there is formation of neuroma. Now let's understand about the Sidon's classification. So nerve injuries are getting classified based on how severe they are into three groups. The first one is a neuropraxia. If it is more severe, it is axonotemesis. If it is more severe, that is neurotemesis. So this is the way the nerve injury occurs based on their severity. So let's understand each of these classifications. First is the neuropraxia. It is a milder grade of injury in which there is a physiological block. So understand physiological block, that means no anatomical structures are harmed. So there is no anatomic block or no damage to the anatomical structure. Only the physiology of nerve transmission is blocked because of some reason. So this is a physiological block and there is no structural changes occurring. So there is no damage to any anatomical structure. Your endoneurium, your perineurium, and also your other structures of the nerve are intact. But there is a physiological block that has occurred, and the recovery occurs spontaneously within a few weeks, and it is a complete type of recovery. So there is a spontaneous recovery, and also the recovery is complete in a case of neuropraxia. So most of the injuries that occur with fractures or dislocations are cases of neuropraxia. So the treatment in these neuropraxia is observation until there is complete nerve recovery. Only if there is no complete nerve recovery within, say, a period of 9 months or 1 year, only then do we go for surgical intervention. So that was about neuropraxia. The second grade is an axonotemesis. In axonotemesis, the axons are getting damaged, but the internal structure of the nerve is preserved. So I told you the internal structure of the nerve contains endoneurium, epineurium, and perineurium. So these structures are intact. It is only the axon that is damaged, and because of that, there is a Wallerian degeneration that is occurring. So in a case of neuropraxia, there is no Wallerian degeneration because here the anatomical structures of the nerve are not damaged. But in a case of axonotemesis, there is damage to the axon body. And whenever there is damage to the axon bodies, that will cause a retrograde degeneration, also a proximal degeneration, and then regeneration. So the whole process of Wallerian degeneration is occurring. Also here, the recovery is spontaneous. It may take many months, but there is a spontaneous recovery. But unlike neuropraxia, it is not a complete recovery. So in neuropraxia, there was a spontaneous recovery. Also, there was a complete recovery. In case of axonotemesis, there might be some deficits left behind even after recovery. That was about axonotemesis. Now let's go to the third grade. That is the most severe grade of nerve injury. That is neurotemesis. Here, the structure of the nerve is damaged by an actual cutting or the scarring of that segment. So it is a complete cut in the nerve. It can be damaged to both the axon and also the epi, peri, or endoneurium. So there is complete damage to the nerve. Also in this case, Wallerian degeneration does occur. So here also anatomical structures are damaged, more severe than axonotemesis. So Wallerian degeneration does occur. Spontaneous recovery does not happen in this case, and there is a need for nerve repair. So in case of neurotemesis, it is very important to identify that neurotemesis early and take for an immediate repair. So a neurovascular surgeon has to be called in so that you can do an immediate repair of such neurotemesis. So now let's understand Sidon's classification with diagrams. First is an image of a normal nerve. So here we have the structures of the nerve, that is the endoneurium, the epineurium, and the perineurium, and all of this are intact. Also, we have the axon inside. So the axon that is present inside, and also there is nerve transmission that is occurring, normal nerve transmission. In a case of neuropraxia, this normal nerve transmission is getting blocked. So there is a conduction block, but still the axon and the endo, epi, and perineurium are still intact. But in case of an axonotemesis, you can see here that there is a damage of the axon. So axons are divided. In a case of neurotemesis, there is complete damage. So you can see here, all your epi, endo, perineurium and your axons are damaged. So there is a complete nerve resorption or a disruption, and that is why this requires an emergency nerve repair. and that is the Sidon's classification. 3 types: Neurotemesis, Axonetemesis, and Neuropraxia. Let's understand few features about the Sidon's classification. In Neuropraxia, I've told you that there is a physiological interruption, but the anatomy is still normal, and the degeneration is not present because there is no anatomical structures being damaged, and there is no neuroma forming as well. And the recovery is within 6 weeks. But in a case of an axonetemesis, the axons are broken, but the nerve is intact. So there is degeneration occurring both distally and proximally. Also, there can be presence of a neuroma in continuity because in this case, regeneration is happening, so there might be neuroma formation. Also, the recovery occurs here, but not a complete recovery. There might be a partial recovery, but spontaneous recovery does happen, and there is a motor march seen, that is, muscle recovery occurs proximal to distal. Next, coming to neurotemesis. In neurotemesis, both the nerve and the axons are damaged. So here also, there is a degeneration proximally and distally, and if the endoneural tube is not intact, there will be end or side neuroma forming. So there can be complete regeneration. Also, there can be formation end or side neuromas, and in this case, the recovery is poor, and you always have to go in for a surgical repair of the nerve. So now that we've understood the general aspects of any peripheral nerve injury, in this session, we'll be discussing about one peripheral nerve in particular, and that is the radial nerve. So let's understand about the distribution of radial nerve and its course throughout the limb, and then let's talk about the radial nerve injuries and compressive neuropathies that occur. So we all know that the radial nerve comes out of the brachial plexus. So from the brachial plexus, that is from C5, C6, C7, C8 and T1, you have presence of all these giving rise to a posterior cord, and from this posterior cord you get the radial nerve. So this whole brachial plexus all the way up to the infraclavicular region, coming all the way till the axilla, gives out the radial nerve. So we know the course of the brachial plexus all the way up till the axilla, where it gives out the radial nerve. So after this, where does the radial nerve travel to? So let's find out the course of the radial nerve. So after the radial nerve comes to the axilla, it passes through a triangular interval. So let me clarify what is a triangular interval, what is a triangular space, and what is a quadrangular space. So there are presence of these muscles here, that is the triceps brachii long head, teres major muscle, and the teres minor muscle. So these three muscles along with the humerus shaft form two triangular space and interval, and also forms a quadrangular space, and there are certain structures that pass through these spaces, which is very important to know. So let me draw a simple diagram to make you understand these structures. So this here is the teres minor muscle, and this is the teres major muscle. Then we have presence of a humerus. So this is the humerus shaft, and then we have presence of a long head of triceps. So this is the triceps brachii long head. Now because of these three muscles and the humerus shaft, there is a triangular space that is formed, there is a quadrangular interval that is formed, and there is also another triangular interval that is formed here. Now from this triangular space that is there, we have a circumflex scapular artery. So there is a circumflex scapular artery coming from that triangular space. From this quadrangular space, two structures are passing by. One is the posterior cutaneous or the circumflex humeral artery, PCHA, and the second one, which is very important, is the axillary nerve. Now we don't want to talk about these two spaces. We want to talk about the space that the radial nerve passes by, and that is this triangular interval between the long head of triceps and the humerus shaft and also this teres major muscle. From that space, we have the radial nerve coming and also the profundi brachii artery. So these two, one artery and one nerve, is piercing this interval. That is a triangular interval formed between the humerus shaft and the long head of triceps and also the teres major. So that triangular interval, from that you have the radial nerve piercing, and then it goes into the spiral groove. So there is a spiral groove in the humerus, and along that spiral groove, that radial nerve and that profunda brachii is passing. So this is the course of the radial nerve after it comes from the axilla. Then it pierces the interval and then it runs through the spiral groove. So I hope this is understood. Now before it pierces, that triangular interval, it gives out one sensory branch and two motor branches. So before the radial nerve along with the profundi brachii is going to lie in that, is going to pierce that interval and going to lie in that spiral groove, it is already giving out two motor branch and one sensory branch. That sensory branch is the posterior cutaneous nerve of the arm, which is supplying the posterior aspect of the arm. And then it gives out two motor branches. Those motor branches are two heads of the triceps. So we know that triceps has three heads. It has a straight head, that is the long head of triceps, it has the medial head of triceps, and it has the lateral head of triceps. So three heads of triceps: long head, medial head, and lateral head. So the long head of triceps and the medial head of triceps, that branch is already given out before the radial nerve passes into that triangular interval. And after that, it runs along the spiral groove. So gives out one sensory branch, gives out two motor branches, that is long head of triceps, medial head of triceps, and then it pierces the interval and starts to run across the spiral groove. From the spiral groove, it is going medial to lateral. Now, while it runs along the spiral groove, it gives out a few branches. That is, it gives out four branches. Two sensory branch, that is to the posterior cutaneous nerve of the forearm and the lateral cutaneous nerve of the arm. So it is already supplied the posterior aspect of the arm. In these branches, it is supplying the lateral aspect of the arm and the posterior aspect of the forearm. So you know that radial nerve is supplying both the posterior aspect of the arm and the posterior aspect of the forearm along with the lateral aspect of the arm. Now coming to the motor branches, it gives out two motor branches. So in the previous, before it comes into the spiral groove, it has already given innervation to two heads of triceps, that is the long head of triceps and the medial head of triceps. In this, when it is running along the spiral groove, it gives out innervation to the lateral head of triceps and also the anconeus muscle. So these are the branches it gives out while it is running in the spiral groove from the medial aspect to the lateral aspect. So once it reaches the lateral part of the humerus, so you know that it is now pierced the space, and after piercing that space, it is run along the spiral groove from medial to lateral. So it is run along the spiral groove from the medial aspect to the lateral aspect, and once it reaches this lateral part of the humerus, it runs downwards 2 to 3 centimeters in the posterolateral part. So 2 to 3 centimeters it runs downwards. After it runs downwards, it pierces the intermuscular septum. So you have presence of an intermuscular septum here. So that nerve pierces that intermuscular septum, and now it is posterior. After piercing the intermuscular septum, this nerve goes to lie anteriorly. So after piercing, it goes from posterior to anterior. So it enters the anterior compartment where it runs anterior to the lateral epicondyle. So after it goes anteriorly, it comes to lie just at the lateral epicondyle region. So that is the course. That is, it goes through the spiral groove. After going through the spiral groove, 2 to 3 centimeters, it runs posterior laterally, and then it pierces the intermuscular septum. And after piercing the intermuscular septum, it goes from posterior to anterior, and anteriorly it runs very close to the lateral epicondyle. So as we can see in this diagram, this is the radial nerve. So you can see that the radial nerve is running across the spiral groove, and then it comes into this part here, that is the intermuscular septum. So as it runs in the spiral groove, coming medial to lateral, and once it comes lateral, it pierces something called as the intermuscular septum. And once it pierces this intermuscular septum, it goes from posterior to anterior. So it goes from the posterior compartment and comes to lie in the anterior compartment. Now in the anterior compartment, it runs downwards and it comes close to the lateral epicondyle. So the distance between the lateral epicondyle and that intermuscular septum is 7 to 10 centimeters. So once the radial nerve pierces that intermuscular septum, it runs downwards 7 to 10 centimeters to come to lie somewhere near the intercondylar line or the elbow joint, very close to the lateral epicondyle. Now let's understand the course. So we've talked about it piercing the intermuscular septum, and after that it runs between brachioradialis and the brachialis muscle. So in this diagram you can see that it is lying between this muscle here, that is the brachioradialis, and this muscle here, that is the brachialis. So the radial nerve, after it comes anteriorly, is lying between these two muscles, that is brachioradialis and brachialis. So it runs up to the elbow joint, and in the intercondylar line, it divides into a superficial branch and a deep branch. So you can see in this diagram, it is running across between the brachioradialis and the brachialis, and once it comes up till the intercondylar line or the elbow joint, in this position, it is giving out a very important branch. That is, it is dividing into a superficial branch and a pure branch. So you can see here, a deep radial nerve and a superficial radial nerve is formed. This superficial radial nerve is a pure sensory type of nerve, and the deep radial nerve is a mixed type, mainly motor type of radial nerve. So this is a very important division. You need to know where the radial nerve divides into a superficial and a deep radial nerve branch, and that is at the intercondylar line. Now between the intermuscular septum and the intercondylar line, so after it pierces the intermuscular septum and it is running between the brachioradialis and the brachialis all the way up till the intercondylar line before it gives out its branch of sensory, that is your superficial and your deep radial nerve. Before that happens, that middle place between the intercondylar and the intermuscular line, that area, it gives out a brachioradialis branch. So you know that it is running between the brachioradialis and brachialis. So it supplies both of them. It supplies the brachioradialis, it also supplies the brachialis. And brachialis, you have to remember that it has a dual supply. Some muscles have supply of two nerves, and brachialis is a type of dual supply nerve where the nerves are the median nerve and the radial nerve. So both of these nerves supply the brachialis, that is median and radial nerve. It also supplies the extensor carpi radialis longus. So between the intermuscular septum and the intercondylar line, the radial nerve supplies brachioradialis, brachialis, and also extensor carpi radialis longus. Now let's understand the deep branch. So we know that in the intercondylar line, it is getting divided. A very important division of the radial nerve is happening. It is getting divided into a sensory branch, that is a superficial radial nerve. Another important branch is the deep radial nerve. So first let's trace the course of the deep radial nerve, and once we're done with that, then we'll come to where the superficial radial nerve goes. So this deep radial nerve will get pierced inside the supinator muscle, and this is a hiatus. So in the supinator muscle, there is presence of a sciatus or a hiatus that is there, and this hiatus is called as the arcade of Frosch. So very important to remember that radial nerve, that is a deep radial nerve, goes inside a hiatus in the supinator muscle, and this hiatus is called as the arcade of Frosch. So this is a hiatus in the supinator muscle, and it's only the deep branch of the radial nerve which enters the arcade. So this arcade, only the deep branch is entering. The superficial branch is going somewhere else. Also, it goes from anterior to posterior compartment. Hence, it is called as the posterior interosseous nerve. So let me explain this. First, the deep branch, after it gets divided, goes into the hiatus of the supinator muscle. And once it goes into the hiatus of the supinator muscle, then it pierces the interossei. So there is an interossei between the radius and the ulna. So after the supinator muscle is pierced, this radial nerve pierces the interossei muscle, and then it goes from the anterior compartment of the forearm to the posterior compartment of the forearm. That is how it is again changing compartment. So after it pierces the supinator muscle, it pierces the interossei muscle and then it goes posteriorly. And because it is going posteriorly and it is piercing the interossei, this nerve is called as a posterior interosseous nerve or a pin. So that is how the deep branch is getting converted into a posterior interosseous nerve. Now let's understand that before going into the arcade of Frost, what branches it gives. So before it pierces the supinator muscle, it gives out two branches, one to the supinator muscle and another to the extensor carpi radialis brevis. So before it reaches the intercondylar line, it's already given out extensor carpi radialis longus. So here, before it pierces the supinator, it gives out branch to the supinator and also to the extensor carpi radialis brevis. Now, in the posterior compartment of the forearm, so I've told you that after it pierces the arcade, it goes and pierces the interossei and it goes from the anterior compartment to the posterior compartment. Now, in the posterior compartment of the forearm, once the posterior interosseous nerve, that is a pin, enters the posterior compartment, it runs between the superficial and the deep part of the extensor muscle. So, in the posterior compartment, there are a lot of extensor muscles. So this pin nerve is going between the superficial and the deep muscles, and that nerve is then supplying all the extensor muscles in the forearm. So in this junction, it supplies all the muscles of the extensor compartment. So all these muscles that are present in the posterior compartment of the forearm are supplied by a branch, that is a deep branch of the radial nerve, and that is called as a posterior interosseous nerve. So what are these extensor muscles in the forearm that it is supplying? It is supplying the extensor carpi ulnaris, the extensor digiti minimi, the extensor digitorum longus, the extensor indicis, abductor pollicis longus, extensor pollicis longus, and also extensor pollicis brevis. So all these muscles which lie in the posterior compartment are being supplied by posterior interosseous nerve. So I hope this is clear. Now let's understand about the superficial branch. We talked about the deep branch. We talked about where the deep branch goes. Now let's talk about the superficial branch. We know that in the intercondylar line, the radial nerve has got divided into a deep branch and a superficial branch. We also know that this superficial branch is a purely sensory branch. So let's find out where does this sensory branch supply. So first, it branches at the intercondylar line. It branches into deep and superficial. So the superficial runs next to the radial artery below the brachioradialis. So along the brachioradialis, below it, it runs along with the radial artery. And then it runs till the wrist joint. And in the wrist joint, it pierces the deep fascia and it enters into the extensor compartment. So it pierces at the wrist joint, it pierces the deep fascia and then it extends or enters into the extensor compartment. So it's just like the deep branch, even this is coming into the extensor compartment. Here in the extensor compartment, it supplies the anatomical snuff box. So the main innervation of the superficial branch or the sensory branch is this anatomical snuff box. So the anatomical snuff box is present in the extensor compartment or present in the dorsum, and it is mainly at the base of the first and the second finger. So that part, that groove that is there between the base of the first finger and the second finger is called as the anatomical snuff box, and that is the main innervation of the superficial branch. So you can see in this diagram how it is growing across the brachioradialis along with the radial artery, and finally it is supplying this space that is there between the base of the first and the second digit, and that space is called as the anatomical snuff box. Now let's talk about the sensory supply of the radial nerve. So the sensory branch of radial nerve is mainly the superficial or the sensory nerve, the superficial radial nerve that is there. So this superficial radial nerve supplies the anatomical snuff box. Along with that, it also supplies the whole of the first finger. It supplies the second finger all the way up till the PIP joint, that is a proximal interphalangeal joint, and it also supplies half of the second finger. So this much area is the supply or the sensory supply of the superficial radial nerve. That is 2.5 fingers, and the second and the third finger all the way up till the PIP joint. So now that we've understood about the course of the radial nerve all the way from the axilla up till the hand, now let's understand what are the pathologies that affect the radial nerve. The pathologies can be nerve injuries or they can be compression at some point. So that is called as a compressive neuropathy. So first let's understand where does this compressive neuropathies occur. So let's understand about the compressive neuropathies of the radial nerve. So the first can occur at the axilla. So we know that the first area where radial nerve comes from is the axilla. So at the axilla region, if the radial nerve gets pressed to the humeral head, that can cause a compressive neuropathy. So that usually occur in people using crutches. So people using crutches, if there is increased pressure because of an incorrect usage of crutches, that can lead to radial nerve getting compressed by that crutch against the humeral head. So there can be chances of something called as a crutch palsy. So that occurs at the axilla. Second is we know that the radial nerve passes through the spiral groove. So there can be compression of this radial nerve at the spiral groove. And this usually occurs in people who after drinking sleep in an uncomfortable position. That is, they sleep on the chair with their hand being compressed against the chair. So there is compression of that chair on the radial groove, and that is where the radial nerve is getting pressed. And this usually happens in people after Saturday night, where they go out, drink and come back and lie in such an uncomfortable position. So this is called as a Saturday night palsy. So this is the second site where compressive neuropathy can occur, that is at the spiral groove. The third one is at the radial tunnel. So let me tell you what a radial tunnel is. So we know that the radial nerve passes through the intercondylar joint. So it can get compressed at the radiocapitular junction. Also, it can get compressed at the extensor carpi radialis brevis area. Edge of the extensor carpi radialis brevis can cause a compression. Third is the arcade of Frost. So I told you that there is a hiatus in the supinator through which the radial nerve passes, and that is the arcade of Frost. In that site, there can be compression. And the fourth is the deep edge or the distal edge of the supinator. So in all four of these areas, there can be compression, and such a compression is called as a radial tunnel syndrome. And the main nerve affected is the pin muscle, that is the posterior interosseous nerve. So these are the areas where the compressive neuropathies can occur. There is another compressive neuropathy which occurs for the superficial radial nerve. The superficial radial nerve can also be compressed, and when this compression happens, it is a pure sensory compression because the deep branch is still intact. That is why the motor functions are intact. Only thing is the anatomical stuff box innervation or the sensation is lost, and that is called as the Wartenberg syndrome, and we'll talk about that in the coming slides. So next is about nerve injury. So this nerve injury of the radial nerve can occur in different sites. We know that the nerve runs from the axilla all the way up till the hand or the wrist joint. So this site of nerve injury can occur in any of these sites. So to understand it better, we've divided them into three zones. That is the very high radial nerve palsies that occur before the nerve reaches the spiral groove. So before that nerve is present in the axilla and then it goes to the spiral groove. At the junction where it is going into the spiral groove, that is a very high radial nerve palsy. And second is a high radial nerve palsy. So up until it reaches the intercondylar line or near the septum or the intermuscular septum where it is getting pierced, till there, if there is any injury to the nerve, that is called as a high radial nerve palsy. And the area below that intermuscular septum and the intercondylar line, if there is any injury occurring distal to that, that comes under a low radial nerve palsy. So these are the three types of radial nerve injuries. Very high radial nerve injury usually in the axilla. High radial nerve injury is when it reaches the spiral groove and also up until it reaches the intercondylar line. Now the low radial nerve palsy is below the elbow and all the distal aspects. So first let's understand very high radial nerve palsy. So in very high radial nerve palsy, right up in the axilla, you know that the first supply is given at the axilla, distal to the axilla, just before it reaches the spiral groove. It gives out branches into the long head of biceps and the medial head of biceps, and also it gives out a sensory supply to the posterior cutaneous nerve of the arm. Now if there is an axilla damage, even these nerves are getting affected. So because the radial nerve very high up is being damaged before it gives out any supply. So in this case, usually all the motor functions are lost and sensations are lost posterior to the arm and the forearm. So you know that the posterior cutaneous nerve of the arm is supplied very distal, just before it goes into the spiral groove. That is when the supply is given. Now in very high radial nerve palsy, even that is affected. That is why posterior aspect of the arm, forearm, and even the wrist and the 2.5 fingers, that is the anatomical snuff box, all of this sensations are lost. Even motor, all muscle sensations or motor functions are lost. And this usually occurs if there is a humeral head dislocation, or like I told you, in crutch palsy. So if there is incorrect usage of crutch, there will be crutch palsy, and also in humeral head dislocation. In these cases, you see a very high radial nerve palsy. All the sensation and all the motor functions are lost. Second, we talk about high radial nerve palsy. So that can occur because of a prolonged tourniquet use, or in humeral shaft fractures, or in infections. So high radial nerve palsy is from when it enters the spiral groove all the way up till the intercondylar line. So in these areas, if there is a humeral shaft fracture, that will cause a radial nerve palsy. Also, injections are given or a prolonged tourniquet is applied, and because that tourniquet will get pressed against the humeral shaft, causing a radial nerve palsy. So let's find out the features of a high radial nerve palsy and how it is different from a very high radial nerve palsy. So in a high radial nerve palsy, extension at elbow is still present. Why is there extension at the elbow? This is because just before it enters the spiral groove, it is giving out a few branches, and those branches are, so you know that this is the humerus, and right when the nerve enters the spiral groove, so if this is your spiral groove, right before it enters the spiral groove, it is giving out one branch for the medial head of triceps. It is giving out another branch for the long head of triceps. And right near the spiral groove, that is here, it is giving out a branch for the lateral head of triceps. So because these three branches are intact, that is why extension at the elbow is still present. Second is posterior arm sensation is also present. That is because there is one sensory branch that is given out. So this one sensory branch is given out just before it enters the spiral groove, and that is the posterior cutaneous nerve of the arm. So because this branch is given out before it reaches the spiral groove, that is still intact, and that is why posterior arm sensation is still present. There will be wrist drop, there will be finger drop because all the extensors of the forearm are damaged. There will also be thumb extension that is lost, and sensations are lost in the first web space. So this compression happens before it divides into deep and superficial branch. So both the deep branches and superficial branches are affected. Because the deep branch is affected, there is a wrist drop, there is a finger drop, and there is thumb extension loss. So extension of the wrist and the forearm is lost. That is why there is finger loss, finger drop, wrist drop, and also there is a thumb extension that is lost. Now even the superficial branch is affected. That is why sensations at the anatomical snuff box is also affected. So now let's understand about low radial nerve palsy. So in low radial nerve palsy, it occurs distal to the intercondylar line along the area where there is a division between the superficial radial nerve and the deep radial nerve. So we know that at that level, there are few innervations already given. So innervation to a muscle that is brachioradialis, brachialis, ECRL and anconius. So these muscles are already innervated before it goes below the intercondylar line. So when there is a low radial nerve palsy which is occurring below the intercondylar line, these four muscles are still intact. So when you want to test for a low radial nerve palsy, you will always look for functions of the brachioradialis muscle and the extensor carpi radialis longus muscle. So if these two muscle functions are active, we know that the injury is a low radial nerve palsy. Now we know that even the brachialis and the anconius muscle is intact, but they cannot be tested. These muscles cannot be tested. Hence, we use brachioradialis and ECRL as the main parameter to determine between a high radial nerve palsy and a low radial nerve palsy. So when does this low radial nerve palsy occur? It occurs in elbow dislocations. It occurs in radial head fractures. If there is an iatrogenic injury, or in cases of rheumatoid synovitis, where because of the synovitis, there will be a traction and injury to the nerve. Now, in these cases, we'll have weak wrist extension. There will be wrist extension present, but they'll be weak because the forearm extensors are still damaged. Also, there'll be finger drop and there will be a radial deviation. This is because of action of the opposite nerves and damage of the action of the main nerves, that is the extensor muscles of the forearm. Now let's understand the autonomous zone of the radial nerve. So in the arm and forearm, the innervation or the sensory supply of three nerves, that is the median nerve, ulnar nerve and radial nerve, is very mixed. So whenever you're testing for any nerve, you know that there is certain amount of superimposition between two nerves acting in the same region. So if you want to know the function of just one nerve, then you have to check for the autonomous zones of each of these nerves. So for the radial nerve, that autonomous zone where only the radial nerve is supplying and no other nerves are supplying is the first web space in the dorsal aspect. So if you want to check for a suspected radial nerve injury, always check for sensation at the first web space in the dorsal aspect, because that is the autonomous zone of the radial nerve. Now coming to the sensory. Now we've talked about compressive neuropathies. We have talked about injuries occurring to the main motor branches of the radial nerve. There is one compressive neuropathy that occurs to the superficial radial nerve. So you know that the radial nerve at the intercondylar line divides into a deep radial nerve and a superficial radial nerve. And we also know that this superficial radial nerve runs below the brachioradialis, goes all the way up till the wrist, where it pierces the deep fascia, enters into the extensor aspect, and then it supplies the dorsal aspect, that is the anatomical snuff box. So there can be compressive neuropathy of this superficial radial nerve occurring externally or internally, that is between the brachioradialis and the extensor carpi radialis longus. So this compressive neuropathy occurs in between the brachioradialis and the extensor carpi radialis longus. And because of this compressive neuropathy, there will be paresthesia at the dorsum of the wrist and the lateral 2.5 fingers. So I told you that an innervation of the radial nerve is this anatomical snuff box and also the whole of this thumb and also half, that is till the PIP of the second finger and almost half of the third finger up till the PIP. So this much aspect, the sensation will be lost if there is a compressive neuropathy of a superficial radial nerve, and that compressive neuropathy is called as the Wartenberg syndrome or also called as a chiralgia paresthetica. So it is called as a Wartenberg syndrome or chiralgia paresthetica. Now coming to treatment. So you know that there is a radial nerve injury that has occurred. So what are the options to treat them? first you have to grade whether it is a neuropraxia or it is a neurotemesis or axonotemesis. If it is a neuropraxia, that is, there is a Sidon type 1. So in Sidon type 1, we know that it is a conduction block. So in such cases, observation for recovery is enough. You do not have to do any surgical recovery. In Sidon type 2, also we follow this observation technique, but if that does not happen or there is some nerve deficit, that has to be operated on. But in Sidon type 3, that is, there is a neurotemesis. In such cases, you have to do a nerve repair. That is an immediate and emergent nerve repair. So what are the options? So you can do a surgical nerve repair. That is a primary repair. You get the cut ends of the nerve and then you suture them layer by layer. That is a surgical nerve repair. But if there is a loss of certain amount of area, then you have to do a nerve grafting. That is, you have to take the nerve from somewhere else and then graft it into this muscle. Also, you can do a nerve transfer. In some cases where even you wait for 9 to 12 months and then there is no recovery seen, even in Sidon type 1, 2 or 3, if there is a nerve injury which you suspected to be a low-grade injury and you waited for 9 to 12 months and there was no recovery, in such cases you cannot do a nerve repair after 1 year because the ends of the nerve are now more sclerotic or more atrophic. So you can't do a primary nerve repair. In such cases, you have to replace the tendon. So if there are tendons that are faulty, you have to replace them with other tendons, and that procedure is called as a tendon transfer. So you wait for 9 to 12 months if there is any nerve regeneration. If nerve regeneration does not happen, then those deficit tendons are being replaced by functional tendons, and that procedure is tendon transfer. So there are a lot of tendon transfers that can be done for radial nerve injuries, but we'll mainly be studying about one tendon transfer, a popular one, that is the Jones transfer. So we know that in a case of radial nerve palsy, there is a loss of extensor carpi radialis longus and extensor carpi radialis brevis. There is loss of the extensor digitorum communis, and there is also loss of extensor pollicis longus. So all these extensor muscles are damaged in a case of radial nerve palsy. And because of this, we'll have a wrist drop, a finger drop, and loss of thumb extension. Okay, so we have to restore the extension of the wrist, we have to restore the extension of the finger, and we also have to restore the extension of the thumb. So how do we do that? We use the functional tendon. So we know that the extensor compartment is damaged, but the flexor compartment is still intact. So we are borrowing 3 muscles or 3 tendons from the flexor compartment and we are using them in the extensor compartment. So in the place of extensor carpi radialis longus and ECRB, we are using pronator teres. So this pronator teres will bring back the wrist extension. Secondly, for the use of extensor digitorum communis, we are using flexor carpi ulnaris, and this will bring back the finger drop, or it will get back the extension of the fingers. And third, we are in place of extensor pollicis longus, we are getting flexor carpi radialis. So this will bring back the action or the extension of the thumb, and this whole procedure of transferring pronator teres, flexor carpi ulnaris and flexor carpi radialis in place of these extensor muscles, this procedure is called as the Jones tendon transfer. So now let's summarize about peripheral nerve injuries and then about radial nerve palsy. So in peripheral nerve injuries, we first talked about the cause. The main cause orthopedically is when there is a fracture or a dislocation, or when there is a direct cut or a laceration wounds. Other things can be thermal injuries, diseases, also presence of cold or frost bites, and many other causes to which nerve injuries can occur. Next, we talked about pathology. In pathology, we talked about how the nerve gets damaged, and that process is the Valerian degeneration, and then how the nerve regenerates, and if there is no intact endoneural tube, how that nerve can go into something called as a neuroma formation. So that was about the pathology of nerve injury and nerve regeneration. Then we talked about the Sidon's classification. So the Sidon's classification classifies nerve injuries into three options. The first one, the milder form, is a neuropraxia. The second one is an axonotemesis. And third one is a neurotemesis. In neuropraxia, there is only a physiological block. Anatomically, it is intact. In axonotemesis, there is an axonal damage, but the inside structures are still intact. In a case of neurotemesis, there is complete damage, and neurotemesis is a grave prognosis which needs to be operated immediately. That is, nerve repair has to be done immediately. So that was about Sidon's classification. After that, we talked about the radial nerve palsy. So first, we talked about the anatomy of the radial nerve, how it starts from the brachial plexus, from the posterior cord at the axilla. In the axilla, it runs later on in the spiral groove, and from the spiral groove, it then pierces the intermuscular septum, goes all the way up till the intercondylar line in the anterior part of the arm. After that, it divides into a superficial and a deep radial nerve branch. The deep radial nerve branch then pierces the supinator in something called as the arcade of Frost, and then goes and forms a posterior interosseous nerve which pierces the interossei, goes back to the posterior compartment, and supplies all the extensor muscles of the forearm. Also, the superficial radial nerve goes along the brachioradialis and goes up till the anatomical snuff box, and in the extensor compartment along the extensor or the anatomical snuff box, it gives out sensory innervation. So that was the course of the radial nerve. Then we talked about the levels of the palsy. So palsy of the radial nerve can occur very high, can occur high, or in the lower part. When it is occurring very high, it damages all the muscular, that is motor, and the sensory branches. If it is occurring in a high radial nerve palsy, you know that the medial head and the long head, and even in some cases the lateral head of the triceps is still intact. And because of this, there can be extension at the elbow that is still intact, and also the posterior cutaneous nerve of the arm is intact, because of which posterior supply of the arm is still intact. There is no anesthesia of the posterior aspect of the arm. So that is how you'll know that it is a high radial nerve palsy and not a very high radial nerve palsy. Now we also talked about low radial nerve palsy, where we know that brachioradialis and brachialis and extensor carpi radialis longus and anconeus muscles are still intact. That is why if you test for their functions and they are intact, you know that it is a low radial nerve palsy and not a high radial nerve palsy. So these were the level of radial nerve palsies. We also talked about compressive neuropathies. These compressive neuropathies, if they occur at the axilla, that is because of a crutch palsy. They can also occur at the spiral groove, that is called as a Saturday night palsy, and also occur at radial tunnel. In the radial tunnel, it can occur at four sites, that is a radiocapitellar joint, or at the supinator edge, or at the extensor carpi radialis brevis edge, or at the arcade of Frost. So if they occur in these four sites, the main nerve involved is the posterior interosseous nerve, and this is called as the radial tunnel syndrome. It can also cause a compressive neuropathy at the superficial radial nerve, that is between the extensor carpi radialis longus and the brachioradialis, and this syndrome, where there is hypoesthesia at the anatomical snuff box because of a compressive neuropathy of a superficial radial nerve, is called as a Wartenberg syndrome or chiralgia paresthetica. So this is all about compressive neuropathies. Lastly, we talked about treatment. In treatment, if there is a complete nerve break, in such cases you have to do a nerve repair or a nerve grafting. But if you suspect that there can be some nerve recovery, that it is a Sidon type 1 or a milder case of Sidon type 2, in such cases you have to observe up till 9 to 12 months, and usually there is complete recovery. If there is no recovery occurring even up till 9 to 12 months, in such cases nerve repair cannot be done. We do something called as a tendon transfer, and the most popular tendon transfer in radial nerve injuries is a Jones transfer. So that was all about the basics of peripheral nerve injuries and about radial nerve palsies. That's all for this session.